On day one, we talked about type 2 diabetes. Here, the clinical idea is very clear. There's a chronic disease of type 2 diabetes that we've oftentimes studied for many, many different reasons, whether that be an indication for a wide array of treatments or also as an outcome that we want to study. And from a methodologic perspective, what we tried to showcase here is how we can actually go through the end-to-end process of developing a phenotype using Atlas, with using Atlas as a tool to develop the cohort definition, Phoebe as a tool to recommend concept sets, and then we used cohort diagnostics as a tool to evaluate the definitions that we created. In the case of type 2 diabetes, some of the interesting insights here is to think about diabetes as the broad classification, which includes different subtypes of diabetes, such as type 1 diabetes, type 2 diabetes, and secondary diabetes, and what that can actually mean as it relates to us trying to reach greater specificity and making sure that we really are finding our type 2 patients, not just anybody with broad scale diabetes. The other thing we highlighted here is the notion of index date misspecification. One of the things I highlighted as we talked about this is that if you're trying to find newly diagnosed patients, when is the index date of someone being newly recognized as diabetes? And what we saw is that the first time someone had a diagnosis, actually prior to that diagnosis, they might have already been treated with a type 2 diabetes drug, or they already had an HbA1c measurement value greater than 6.5. So they already had diabetes prior to the moment that they were first diagnosed. And so thinking about the methodologic issues about how do we create cohort definitions that actually have good index dates is an area that, if you're interested in that conversation, type 2 diabetes could be a good conversation for you to read about and join in the conversation. Day two, I talked about type 1 diabetes. I was surprised that was one of the highly voted items for the group, but I decided to tackle that given we had just done type 2 diabetes. And here, again, using cohort diagnostics, we had a very contrasting story. Whereas the type 2 diabetes definition looked generally pretty good and reasonable and matched our clinical intuition, the type 1 diabetes definition that I posited as a starting point actually looked like a horrible definition, because we would expect that most type 1 diabetics would be newly diagnosed maybe in their early teens or early 20s. We would expect that most type 1 diabetics would actually be treated with insulin. And yet what we actually saw in certain databases was a pattern that made it look like we actually had misclassification of type 1 diabetics who were being pulled into our definition, even though they probably were type 2 diabetics. And so the issue of misclassification and what we might actually do about it became part of this conversation. Joel Swerdell added a bunch of really nice commentary on the end of this, using Phevaluator as an approach for us to quantify the measurement error. And it really highlighted opportunities for us to improve the phenotype development, the phenotype algorithm itself. And so if you're interested in those types of topics, I'd encourage you to take a look at day two. On day three, I talked about atrial fibrillation, highlighted that there were several papers that have been published very recently trying to create phenotypes on atrial fibrillation, and notably pointed out that some of them actually had different codes to define the same clinical idea. Here, I wanted to showcase specifically the process of how you could take a published paper with its own set of local source codes. Oftentimes in the US, those would be papers published with an ICD code list, an ICD-9 code list, or an ICD-10 code list. And I walk through the process of how you could actually replicate an existing definition. So without regard to whether it's good or bad, just the idea that you want to produce what was done in a paper. Sometimes people misinterpret the OMOP Common Data Model and Odyssey vocabularies as something that basically says because you start with ICD codes, you can't use ICD codes as part of the phenotype development process. And nothing could be further from the truth. If you want to start with an ICD list, you absolutely can, and it can be a useful starting point to build a phenotype. And so in this conversation, I just wanted to start talking about how does one actually go about learning from an existing published definition, and then how can we actually implement that in our own environment. And so for those of you interested in atrial fibrillation or that process to discovery, feel free to check that out on day three. On day four, we dove into oncology and specifically looked at multiple myeloma as a disease target. This conversation was really to highlight that there are specific, in the oncology space, we often talk about that you really need a lot of specialty data to be able to reliably identify specific cancers, and that can be true for specific subtypes, but there's still an awful lot we can learn from general population data sets. And so in this particular case, I showcase how we can actually implement alternative definitions for multiple myeloma, again, looking at literature-based definitions that actually use procedures and treatments as part of the regimen, and we can actually see the impact of those choices. So check that out. On day 5, I highlighted Alzheimer's disease and specifically highlighted that there have been a range of different papers, and interestingly highlighting a paper that was led by Dave Kern and Soledad Cepeda in our community, which specifically thought of the problem of if you're targeting Alzheimer's disease, and Alzheimer's disease specifically is a phenotype that might have low sensitivity, meaning that you're missing some of the people that actually have Alzheimer's disease. Maybe a strategy you could take is to actually create a phenotype for dementia as the broader idea and use that as a more sensitive variant of Alzheimer's disease. And I highlighted how you could actually create some of those implementations and think about the differences of there. So if you're interested in Alzheimer's disease or how to use multiple alternative definitions, this is a good chat to get a part of. Day 6, hemorrhagic events. Lots of people are interested in bleeds for lots of reasons. And yet it actually turns out that there's lots of very thorny algorithms out there for how do you kind of figure out whether or not a bleeding event is actually taking place. And so we examine a recent paper by Wayne Ray and colleagues that provides a pretty elaborate definition for how to create bleeding-related hospitalizations. We implement it in the Odyssey tools, and then we also evaluate whether or not we could create a more generalizable approach to that phenotype that would work in some data sets that are not just US administrative claims data. And so if you're interested in that topic, I'd encourage you to take a look at day 6. And day 7 yesterday, I posted about neutropenia. I saw Anna Scharfman was on the call for it. I know that she and Wojciech and others hate the fact that measurement data are noisy. And this is, of course, a problem that affects many of us who have data, particularly in electronic health record data, where even if we standardize to the OMOP common data model, that does not mean that we have one measurement concept for one clinical idea. It doesn't mean that we've normalized to one unit. And it doesn't even mean that we even know what the actual plausible range of values could be for that measurement. And yet the reality of it is data sets may have outpatient labs, outpatient diagnosis, inpatient diagnosis, and you might want to create a definition that tries to make use of any and all of that information to find a clinical idea. And so in this discussion, we talk about tools such as ARIES as an approach to use your Achilles results as a way to find what measurement unit pairs actually exist in your data, and to figure out what plausible ranges actually are occurring so that you can create a definition that handles the fact that measurement data are noisy. Day 8, we did kidney stones. My fun fact for kidney stones was that I had to go all the way back to read about the incidence of recurrent kidney stones in the Royal Navy back in the 1960s to be able to understand the current state of knowledge of this disease. That is freaking crazy that that's the current state of knowledge, but nonetheless, we could show that how we could use Odyssey tools to actually create phenotypes and see the impact of our phenotype definitions on the recurrence of disease. Aza, fun fact for delirium.
I got confused halfway through delirium. What is delirium and what am I looking for? Because I started with thinking that I understood what delirium, but then the more I read, I realized that, well, sometimes we're talking about hospitalized delirium, and that's a very specific situation. That's very different than people showing up to the hospital with delirium. So I understood the value of understanding the clinical idea before you touch anything and know what your target is.
Very good. Thank you, Aza. And also special gold stars for Aza for being the first volunteer in our community to initiate a conversation, which was wonderful to see. That not only did she initiate a conversation, but actually was all started on 3 days earlier on Friday when the office hours we had a request of, hey, do you know how to phenotype delirium? And this is now turned into a great community contribution. So thank you, Aza, for that. Joel led us on day 10 for lupus. Joel, what was your fun fact?
Well, the big thing that I learned is going back to Odyssey and the power of community. Some of the contributions that people have put in, especially shout out to Ajit and his colleague at Amgen, who gave some helpful suggestions for it, and I think they're going to be big improvements to the algorithms based upon what they said.
Very good. Thank you, Joel, and thank you for both posting and initiating this conversation on lupus, as well as demonstrating very nicely how Phevaluator has been very applicable to add to many of the conversations that have been going on this month. Aza double dipped and did a second leadership on the topic of suicide attempts. Aza, your fun fact on suicide, which sounds like an awful thing to say.
I'm between delirium and suicide. I'm not sure it's gonna. Where will I end with my mental powers at the end of this? Okay, so I'm not copying Joel, but my main takeaway from this was it is never done unless you exchange notes with the people who actually did work in the same sphere. So suicide is something that my work in J&J is very interested in, and we've been doing work a lot trying to come with the right phenotype. I thought I solved the problem, at least for my work, and then I put the post and I got so much feedback that I realized that, oh my goodness, I still have things that I did not think of. And precisely for phenotype, I did not put, one have to think how to model the events of phenotype and what exactly is the appropriate washout period between two events to be considered two independent events and not reoccurrence of the same phenomena. So very important, the contribution of the community, very important to talk to others. Literature can serve telling you what's the problems, but nothing is as good as talking to others who know more about the topic.
Very good. And I'll just add to that. I know Christoph's done a lot of important work here, and I think the other lesson learned is we need to remember that a lot of our Odyssey tools and the OMOP CDM and the vocabulary are living objects, and so we need to be constantly mindful of looking at vocabulary mappings, figure out where prior versions were bad and whether or not we can improve them, or whether or not they have already been improved. And I think you and Christoph have been having a good conversation to see where do we get to, and whether or not we're now at a point where we can use standardized definitions, or do we still have a bunch of source codes that we need to work through, which is a great opportunity to connect with our vocabulary team to iterate through those issues. Very good. Day 12, Alan Wu started a conversation on Parkinson's. I didn't see Alan on the list. Is Alan here? Yeah, I didn't see him. In which case, I'll just speak.
Oh, I am here.
Oh, hey, Alan.
Hello.
Can you share your fun fact from day 12?
Well, you know, I just have to be so impressed by this entire group and the energy here. It was an opportunity for me to express a lot of the ideas we've been pursuing on Parkinson's. And my fun fact is that when reading all these things, I'm just going to pick one of them. When is lupus like Parkinsonism? It is when you realize that the two have much more in common, trying to figure out a diagnosis early from very vague codes in Phenotype Phebruary. So learning a lot about the other conditions as well. But thank you for allowing me to be present in this community, and look forward to contributing more.
Awesome. Thank you, Alan. And thank you, Alan, also for the courage to, Alan reached out and said, I don't have an OMOP CDM instance, so is it still something I can participate? But actually, I learned way more about Parkinson's from your post and your clinical expertise that made it actually way easier for me to help you with actually building a phenotype. And I wouldn't have done any of the things that I actually implemented if it wasn't for the leadership and the clarity of thought that you provided. So that was great fun for me too. Day 13, I posted about about attention deficit hyperactivity disorder, sharing one of the experiences we had at J&J over the last couple of years. The short version is, do not trust labels of codes. If you think a code is too broad because the label sounds too broad, you need to actually go see what does the data actually tell you. And I provided a little trick here of maybe you could actually create an exposure cohort and look back to see what codes actually get used to represent a disease, rather than making some presumption based on the label that's provided by any ICD or SNOMED code. Galtham kicked off Valentine's Day with a study of heart diseases. And yesterday was kickoff of that for hypertension. Gautam, what was your fun fact about hypertension?
Man, writing the clinical description, hypertension is not easy. It was a long, I had to read a textbook, write a summary on it, and so on and so forth. But the time that was spent on clinical description was worth it because it just sped up the rest of the steps of phenotyping. So my fun fact and my learning is spend all the time you want on writing the clinical description because that's going to help you and you're going to avoid things that Aza experienced. She started with confusion, she started with delirium. And it was very useful learning.
Very good. Thank you, Gautam. And right back to you. Today, you've kicked off the conversation about acute myocardial infarction. Any fun fact that you'd like to share here?
Yeah, I'm still reading about it. There's so folks have asked about acute myocardial infarction, but I want to understand from the community. Are we talking about non-ST elevated myocardial infarction? Are we talking about ST elevated myocardial infarction? Are we talking about unstable angina? It is a broad topic, so we're still in the clinical description state. And by the end of the day, I need to get into evaluated cohort definition.
Then Gautam, you started a conversation on heart failure on day 16. Share insights and fun facts there.
Same general idea. Again, this one has given me shortness of breath. So please, this is an opportunity to further evolve this clinical idea. I have lots more work to do on this one.
Very good. Yeah, so for those of you who have done prior work in heart failure, it'd really be great to particularly get insights here on the clinical definition of what we're targeting. There's a constellations of different diseases that are represented here in heart failure. And I think as we've seen past studies done, very often heart failure is used as kind of a crude proxy of something else, particularly if we think about like a hard outcome being something like heart failure related hospitalization, which is more of an acute episodic event versus the chronic disease status of heart failure that is sometimes what we want to represent. So having others join in and thinking about how we collectively can develop a phenotype for you would be quite helpful. And then Gautam, in ending up your 4-day run of cardiovascular diseases, you try to tackle cardiomyopathy. You want to share insights and fun facts there?
Yeah. So so my understanding of cardiomyopathy is the cardiomyopathy has not been cardiomyopathy the way we think about it in the past. So that the contemporary definitions of cardiomyopathy is different from historical definitions of cardiomyopathy. And that's important because these days, in the last few years, we have the hypertrophic cardiomyopathy, restrictive cardiomyopathy, and the dilated cardiomyopathy. But in the past, there has been various other subtypes. Plus, what we learned is even though there is certain clinical ideas described in practice, it's not the people when the clinicians call somebody to have cardiomyopathy, they don't mean the same thing. For example, ischemic cardiomyopathy. In some contexts, ischemic cardiomyopathy is not considered cardiomyopathy, and so on and so forth. So there's a lot of variables here, and the biggest insight for me is this is not a one-day activity. This is the beginning of the story.
Very good. Yeah, I think in this one of the things that Gautam shared that I thought was interesting is he fixated on talking about all the different subtypes, and then we looked at the data, and 70% of the records we have are just coded at the non-specific level of cardiomyopathy. So thinking about how we reconcile clinical precision with the broad strokes of what actually exists in data can be an interesting challenge for us to think about, not just for this specific cardiomyopathy example, but as a broad problem that we need to think about for many different phenotypes. All right, and then Aza stole Gautham's account and prevented him from posting something and started a different conversation on day 18 about multiple sclerosis. Aza, can you share your insights and fun facts from that?
Yeah, I think I got 2 insights after starting the conversation on multiple sclerosis. One is that multiple sclerosis, like some other disease, is a disease that can start and then either go in remission or can have relapse. So it goes in different stages for different patients. And when we try to phenotype, one question we might want to answer is what kind of multiple sclerosis patient we are modeling, or at least think that there might be more than one model, and which is the right one that represents the disease itself for the most part. An initial onset of multiple sclerosis is one kind of patient. A patient with multiple sclerosis in remission is another patient. A multiple sclerosis with relapse is another kind of patient. So these are things that might manifest differently in the data. In some cases, we have codes that can indicate something versus the other. In many cases, we don't, and we have to rely on some logic and so forth. So that kind of thinking is something that I realize in multiple sclerosis that it's important to kind of understand these situations. The other insight is multiple sclerosis. There's a lot of literature that talks about the no specificity of observational definitions for multiple sclerosis, or like the claims of the codes used for claims might have low specificity because the disease takes long to be diagnosed, and so the code might be used for ruling out purposes. And what I learned is that there is this general idea about codes in observational data having low specificity. However, it's really not one situation that covers everything. It's not the same for diabetes. It's not the same. Like, we really need to understand the specific situation we're dealing with and not have one rule that goes for all codes have low specificity or all codes have low sensitivity. You have to understand literature can be helpful in this situation. But the more important part of this, my insight was, there are different approaches to improve specificity of a definition, and there is no one solution that's going to work for all the situations. So in the US literature, there's a lot of this idea of using multiple diagnosis codes to improve the specificity. But if you take it and apply this across all data sources, you might actually get to worse situation. So really to think that an approach to improve specificity for one disease in one data source at some point in time is not true for another database in some other time and for other circumstances. So think about this very thoroughly when you're starting to phenotype.
Very good. And I'd say, don't just think about it, empirically test it rather than making assumptions. So all of you out there who were just told in your intro to database informatic class to just do 2 or more diagnosis or one in an inpatient setting, we need to brainwash you from that silly rule, because it is not a one size fits all at all. Very good. Thank you, Azza. Day 19, Adam took the reins and initiated a conversation on triple negative breast cancer. Adam, what were your insights and fun facts from that?
Yeah, so my fun fact is, don't use the concept for triple negative breast cancer to find triple negative breast cancer only. Although it basically, my cancer is difficult, and I had a lot of similar thoughts to what Azza was just mentioning, that you really need access to the data and be able to test your cohort definition, and it's really tied up with the type of data you have and the vocabulary as well. What measurements were used to capture the ER negative status, PR negative status, and HER2 negative status. So yeah, I think I just scratched the surface with this one, and I think for cancer, some of the discussions I had with ICEA are we look for an index on a condition, and then also look for like a biopsy or a measurement within some range of that to try and get a good index for cancer. But yeah, I learned a lot, and thank you.
Okay, thanks, Adam. I think you did a great job of actually showing a nice demonstration of creative ways to think about that trade-off of sensitivity and specificity when using multiple measurement markers for the estrogen receptor, progesterone receptor, and HER2 receptor. You showed how you could either think about requiring that you observe them to be negative, or requiring that you can't observe them to be positive, or what happens if you don't do it at all. And I think that that's a nice rubric to think about when you need to integrate a broad diagnosis, in this case of all breast cancers, with additional information to help us get more down into the specific subtype. So encourage people to join Adam in the conversation of triple negative breast cancer here.
Hey, Adam, this is Thomas. How many of the patients in your cohort had the measurements? So it seems like the two conditions were a condition and a biopsy. How many of those patients actually had indications of measurements?
Well, I only had really limited data to look at this, so I don't have the number off the top of my head, but it was smaller. It was, it dramatically reduced the cohort size to require those measurements, especially the measurement values. So that's why I went the other direction of just requiring that they had a measurement and did not have a positive measurement, as well as had no drugs that that indicated that they were ER positive or estrogen receptor positive. So it had a big impact, yeah.
All right, day 20, we got to the weekend, and Evan started us off on a conversation, finally putting the PH in Phenotype February with a discussion, a very extensive clinical description of pulmonary hypertension. Evan, as you went through this, please share any insights and fun facts that you came across.
Well, I think it just came across there. I just put in a link that demonstrated demonstrates the classification of pulmonary hypertension that actually the WHO has maintained or created some really meaningful distinctions that are often used at the bedside. And one of the things I found kind of fascinating, this is a bit of a prelude to the discussion that's going to be coming, is if you actually look at the ICD and most recent version, ICD-10, that's in deployment, those distinctions that are really maintained by the WHO don't quite make it into the terminology. And I thought that was quite interesting. It's not in every disease where you see the WHO using creating a classification system that's used at the bedside, and it kind of highlights the constraints that the terminology is under in terms of its evolution to incorporate the cutting edge distinctions within a particular disease. And I think Claire last week mentioned the constraints that the CDM is under sometimes in terms of how it evolves. You can imagine how much harder that is, in a system where your main vehicle for counting things is the terminology itself. It winds up being fairly constrained in terms of the way it evolves. So I thought that was an interesting fact. And one of the things that it led me to start thinking about more is just the need for broader feature generation. And Paul, I feel bad. I didn't go into the different imaging characteristics you can see, but they're certainly there. I know. And as a card-carrying medical physicist, I feel a lot of shame right now. But there, I think the potential for things in imaging, echocardiography, which often has very structured reports that could be really amenable to feature generation, EKG. I think there'd be a lot of interesting things that we could look at because the source terminologies are going to be a bit challenging in this space.
That's great. And I think, Evan, your highlight about the fact that the coding designation doesn't actually meet up with the subtypes is also part of the generic explanation for why we see subtypes of diseases get coded at higher level constructs, is because if you're only left with the incompatible constructs, you kind of have to pick the thing that's non-specific just to represent the idea that you have in your head. And we see that play out in a lot of situations where, in hindsight, we look back at the data and start wondering, why did clinicians code it this way? And you're pointing out, maybe because that's actually the best and most appropriate thing that could be done given the constraints that existed in the system.
It also shows what a massive asset the terminology effort is in Odyssey, I think, because in looking at those, and that's another prelude, is that there's a much better alignment with those clinical ideas, and just as more systems, I think, kind of realize the power of the terminologies to help them, manage those changes in the underlying source vocabulary. I think they'll see what a gift that is to medical informatics community as a whole.
Very good. All right, so certainly encourage you to join Evan in the journey on pulmonary hypertension. Then just yesterday, day 21, Asya started us on a discussion of phenotyping prostate cancer, and both sharing some of the work that had been previously done within the IMI Pioneer project, but also exposing some new insights. Asya, you want to share some insights and fun facts with the group?
Sure. So I'm just going to put them together. I think, like, generally when I'm thinking about it, it's never getting boring. And the more you do it, the more you learn about all these nuances and details. Some of them, like Adam's talked about, that you have to consider. And so, like, day one of the conversation, it was one question, and now, like, there's a list of questions that we have to think about. And the more you do, the more questions you know, and the better you get to understand the difficulty and all the challenges that phenotyping has. But I think that's not possible with the power of the community. Like, everything that we can get from the clinical expertise and experience, from all the insight that we can learn from the databases and the expertise that the data, like, and the vocabulary and everything is the only way to make it possible, which kind of highlights the importance of clear description of a specific phenotype, which is pretty much lacking in the literature. But on the other side, the other good part was, don't forget about the data, the power of the data, and how we can do some empirical assessment. I had a lot of fun, but I had to stop at some point not to get too much into that. Yeah, and then let's make it better. I don't think we're done there.
Very good. Yeah, Asya did a really nice example of how you can actually let the data tell you about co-occurrence of elements to give you an empirical basis to make some of the decisions that all too often we see kind of get arbitrarily made by someone saying, oh, it's a 30-day window, instead of actually looking at what the data actually tell us should be the window, which I think is a really powerful tool that we all can take advantage of. So if you're interested in prostate cancer, please join Asya in this conversation that just kicked off yesterday. Starting with Rupa.
Sure. So this was a phenotype I had worked on a while ago, and then now came back to it. And even through this celebration of Phenotype February, I learned so much more. I'd say one of my big takeaways is really thinking about how Phevaluator can help. If everyone, I'll give a high level overview here. For HIV, there's a lot we can learn about using the diagnosis code, a laboratory measurement, and drugs. And we created a few cohorts to really explore all of these things. Some gave us some definitive answers on whether or not laboratory measures exist, how the drugs are being used. We had great conversation by Nige and others about how combination therapy can be used. A lot of people in our cohorts have comorbidities, but really at the end of the day, there were some key things that I think Phevaluators sort of started to bring up to the surface, really around this idea of using a second diagnosis. How helpful is that? Pairing things with medication. So I just wanted to give a highlight, a shout out for Phevaluator. And that's the last thing I'd say is databases do matter. And I think I knew that going in, but how much they mattered really is visible through our evaluation, really looking at Medicaid and Medicare separately from a CCAE, which is really our commercially insured people who are employed, versus those that are getting aid from the government. I think it really starts to highlight some disparities that we see in this disease.
Very good. Thank you, Rupa. Day 23. Jill led a conversation. Jill, can you share your fun fact with the community?
Yeah, I mean, this work started out for me internally at J&J, and it was basically to build some phenotypes to load up our library. And I think some of the things that, internally, this is a pretty, active program. There's things happening. And what I learned is by posting on the Odyssey website or the Phenotype February, is that although we have a lot of clinical experts, we didn't get a lot of feedback on this phenotype, which I think sort of speaks to the fact that there really isn't a whole lot of knowledge known about this. So I feel like for me, one of the takeaways, not only about phenotyping, was just that I think there's a lot of room to contribute here. And I think that our observational data is well suited to do that. And having our really structured phenotype development process is really going to help authors to be able to reference that in future and kind of really provide a very a nice way to develop manuscripts around that and move the field forward. So I think that was my big takeaway.
Very good. Thank you, Jill. Day 24, we heard from Erica about anaphylaxis. Erica, could you share your fun fact?
Yes, and I'm representing both Aza and Marcel as well. And I think our fun fact is that I think maybe our story is a little bit different in that we had a well kind of thought out definition of anaphylaxis, and we were reusing that for the study where we're going to look at incidence rates of adverse events of special interest within COVID patients. And so we were using cohort diagnostics to review how well are these phenotypes performing in our data sets. And what we learned in looking at the IPSI data set is that there was a standard code that IPSI was using for anaphylaxis that wasn't part of our definition. And the reason why it wasn't part of the original definition is if you're using the OMOT vocabulary, there were no source codes that mapped to that specific standard concept ID, but IPSI does manual mapping. So it has their source codes and then they kind of have to say which standard codes. So that's how IPSI got there. And so I think my main takeaway is that even if you have a well thought out phenotype definition, even when you go through and do a study, it's still good and worth your time to review cohort diagnostics because you may learn something new as data kind of changes over time. Or if you have a new data partner, you might learn something about how well the phenotype might perform on that data. In this case, we were able to add that additional standard concept ID. It's not going to impact other data sets as much as it would impact a data set that does that standard source code to standard concept ID mapping. So.
Very good. Thank you, Erica. And on day 25, we heard from Tiffany, Juan, and Bill about depression. Tiffany, can you highlight your fun fact?
Absolutely. So aside from Juan and Bill making phenotyping extra fun, I think what we really learned from our post was that there can be great value in combining different types of phenotyping algorithms, not only to help you identify things you might not know that you're missing, but as a way to meaningfully adjust your assumptions or even recalibrate what you thought was a solid definition, not just only based on a specific population, but also based on the specific concepts that you're looking at with respect to that population. So by bringing in different methods that have different strengths, you result, hopefully, in a stronger phenotype, or at least identify things that you didn't know you should be capturing.
Very good. Thank you, Tiffany and team. And then Asya took us into day 26 with non-small cell lung cancer.
So we started with a team that have done quite a lot of work in oncology, specifically non-small cell lung cancer, like trying to create phenotypes. So it's actually a very interesting discussion. Should we phenotype or not? And what is it that we're trying to phenotype? So the entire exercise was like a very good demonstration that the answer is it depends. To what is it that you're trying to get, the trade-off between the sensitivity and specificity, and like the impact of all the changes like within the treatment landscape and the clinical knowledge that can actually help. So we're still working on it, and the answer is still it depends. But I really want to actually thank everyone who worked and contributed to this. I learned a lot, and we'll keep the community updated.
Very good. Thank you, Asya. Then we had day 27. Anna initiated a conversation about drug-induced liver injury. Anna, can you share a fun fact?
I'm not sure how useful it would be, but it definitely is fun for me. So one day, Patrick mentioned that the DILI problem is largely unsolved. And I was like, yeah, we can add something useful here. And then I looked at the space and found this paper produced by Columbia DBMI. And when I saw 20 pages, that should have warned me that the problem is harder than I expected. And then I thought, okay, let's just implement this phenotype. And it was much harder than I thought, because essentially the acute liver injury codes are very much overlapping with the codes of the conditions of exclusion. So it was hard just to implement the concept sets. And then it was hard to implement the logic. And then I thought, okay, but at least we can review some charts and find some fun things in patient profiles. And then I saw 5,000 patients and I didn't know how to approach them. And finally, when I selected a couple of patients for the chart reviews, I could not draw any conclusions from those charts that I selected because it was so hard to make the decision of whether there were cases or not. So the fun fact is that it's really hard. And I guess we can contribute in this space a lot given how hard it is.
Very good. Thank you, Anna. And I know this is an area that many folks have a high interest in. And so just because it's hard shouldn't deter us. And I see Judy has posted in the welcome to my world. Indeed, this is an area where I think we can solve that hard problem probably by collaborating together and just making incremental progress. All right, day 28, we had Claudia initiated a conversation about severe visual impairment and blindness. Claudia, are you on? Didn't see Claudia on our list. She might not have been able to make it. So I'll say that we were not deterred by the limitations of picking February. And I admire Marcella and David for initiating day 29 of Phenotype February. Marcella or David, are you on to talk about the initiated conversation about acute kidney injury?
Hello, Patrick. Yes, we're here. I think it was not only from us, but it was something proposed by the Phenotype February working group that we should not stop there. And also, I think one of the objectives of the group is to contribute with 2 more phenotypes. So we said we would volunteer for 1 more. And we started this with already some work that David has put together with preferences and a literature review on acute kidney injury. I think what I learned is that it was a lot more complex than I anticipated, this phenotype. And it was a learning experience. I think the most fun was to really discuss this with the community. I know that we just posted it today, but we started discussing this in the Phenotype work group, and we got very nice insights from Gautam, from Evan, Joel Swerdell, discussions also with Kevin Haynes and others on the clinical definition and then on the implementation into Atlas. We also learned to work with the cohort diagnostics, and this is something that we would hopefully post later today. And Lee was supporting us with that. So it was, for us, it was a learning experience, and also going through the discussions and all the different posts from all the 28 previous phenotypes was very good. Someone mentioned it was a master class. It really was. And I think we should put this together. I think we've mentioned already that we should publish the learnings or the best practices in how to phenotype, and continue with the talk and the discussions on how to make this scalable. I think this is very interesting and really a challenging exercise.
Very good. Thank you, Marcella and David.
Patrick, can you hear me?
Yep.
Oh, okay. I had to use my phone. My computer's microphone is not working.
Oh,
so
hey,
this
Claudia.
Is Claudia.
Yeah, can you share your fun fact from day 28?
Yeah, so one interesting thing that I found is that in terms of visual impairment, there are 2 charts that are commonly used to measure visual acuity. The Snellen chart, which was invented in the 1800s, and the ETDRS. Now, this Snellen has been shown to have less accuracy, but is commonly used. Even now, papers recommend it. Just because it seems to be easier. So it seems to me that people want to do the easy thing just because, instead of doing the most accurate thing. And that is a problem in terms of healthcare and everything else. So I thought that was interesting. And there are several papers demonstrating that the ETDRS charts are more accurate. But Anyway, so that was interesting. And the other thing that I wanted to mention was that Gautam constantly mentioned that during the clinical, when we're working on the clinical description, we should not think about the codes. But I couldn't stop myself, from doing that. And I kept hearing his voice, saying, now, stop, reset, start, which is what he wrote in his post. Because, constantly I kept thinking, can I do this? Can I really code this? Instead of just writing the clinical description. So there are some habits that I have to break out of to become a better phenotyper. So that's it.
Awesome. Thank you, Claudia. I want us to be able to break out in our sessions, but I want to again reinforce thank you to all of you who did engage in this Phenotype February activity. I think I'm extraordinarily proud of what we actually accomplished this month. We only started conversations of 28 different topics, but where else in the world would you actually find a community to come together and provide this much depth and scientific rigor, both to a wide array of clinical ideas across pretty much every disease area, as well as really focusing on the fundamental science of phenotype development and evaluation. I feel like as a community, you all helped us really advance the current status of where we're at as a field at large. And I do think that this is a great launching point for us to really try to mature the science of phenotyping for our community and for the broader scientific domain. So I want to thank all of you who led the conversations, encourage the rest of you to engage in all of these conversations that will continue. And for those of you who are thinking about doing the next phenotype, hopefully learn from the insights that have been shared from our community and take advantage of them as you continue your research.